abdul-alim min ash-shaytanir rajim min hamzihi wa nafthihi wa nafsihi bismillahir rahmanir rahim nahmaduhu wa nusalli ala rasulihil kareem amma ba'd. Welcome again, dear viewers, to Medicine and Islam, a program sponsored by Sharjah Television that features topics relevant both to the field of medicine as well as to the great religion of Islam. Alhamdulillah Rabbil Alameen, we will continue today in our nephrology series. Resident nephrologist is Dr. Ibrahim George, who is a consultant here in Sharjah, here in the UAE. This is part 9 of our nephrology series, and the topic today is medications harmful to the kidney. Very important topic. Many people don't know this. Many medications we take every day can actually hurt the kidney. Medications harmful to the kidney. Dr. Abraham, welcome back.
Thank you very much, Dr. Bilal.
A very important topic.
Very, very important topic, actually.
So I think we should start with the one that's the most common one, the one that bothers us the most. That's the non-steroidal anti-inflammatory drugs, widely used for both acute and chronic pain. What can you tell us?
I mean, the key thing is that, sometimes people use, because it's easily available, it's over-the-counter prescription, and you don't need, sometimes you just ask the pharmacist, you can get hold of it. The problem comes even though it is, effective in relieving pain, many times, especially when they have underlying comorbidity, means if they have underlying heart failure or liver problems, or, they are on concomitant treatment, especially with regard to diuretics or other tablets, actually, especially, many people have got underlying high blood pressure, and on top of that, when this insult comes, it can derange the kidney function, because normally our kidney filtration is maintained by, it's a balance between vasoconstrictor and vasodilatory chemicals within our system, actually, and one of the vasodilatory components is mediated by cyclogenase pathway called as prostacyclins and prostaglandins. And with the once you have the non-steroidals, you block that pathway and you give that unopposed action of vasoconstrictor effect on the blood vessels. And if they have already compromised, vasculature or blood supply to the kidney, they can tip that balance, actually. So that is the major kind of thing, actually.
So when people are on other medications and have underlying other chronic illnesses, this is where the real danger comes in.
Old age, because as we get older, we all lose a bit of kidney function. We may get, cardiac problems. There might be underlying liver problems. They might be on concomitant treatment. So people should be extra careful. I mean, is it safe for me to take it, actually, or just because I have headache or knee pain? You shouldn't just go and buy the non-steroidals and then pop it. And again, some of them, have take it on a long-term basis, and if it is going on for many years, actually, and sometimes athletes and these kind of people who are involved in sports, they take it as a habitual kind of thing. In the younger age group, they are fine, but over a long period, over spanning our, let's say, 15-20 year period, you really run the risk of cancer itself.
Well, two things pop in my mind that you mentioned. First of all, in America, there's a growing syndrome of kidney failure amongst athletes because of this long-term anti-inflammatory non-steroidal Brufen and Advil, and this is becoming a syndrome in the States now amongst the professional athletes, because they have to get out there and play, and after the game they're sore, and the other medications just don't work as well. The other thing is, you mentioned the older people, that kidney function tends to gradually decrease with age. So that's one thing. And the other thing is, the older people also tend to have arthritis. And so if this is a chronic pain. And that's another risk factor, taking it long term, isn't it?
It is. And the key thing is, sometimes you may need to take it, but make sure that you monitor your kidney function. Quite often what happens is, people are taking things and there is no monitoring, actually. Either the orthopedicians don't monitor it, or the other relevant physicians. If they keep an eye on things, if they know that things are going off, or their creatinine is rising, or something is getting abnormal, at least you can stop it promptly. Whereas if not, things will worsen, actually, and some of them causes nasty inflammation, which can be long-standing and permanently damages the kidney. I mean, if not taken, if not picked up quite early itself.
And now, in addition, before we move on to the next point, in addition to the kidney problems from this particular class of drugs, the non-steroidal anti-inflammatory drugs, also it has some GI complications.
Oh yeah, I mean, it has got GI, because we should be giving them something to protect their stomach, actually, stomach lining. I mean, again, it can erode that protective stomach lining and predispose people for bleeding tendency, actually, not only commonly in the stomach, but it can be anywhere in the gut itself, actually.
So it can happen also in the lower
the lower part of the GI tract.
I thought it was confined to the gastromycosa and the duodenal area.
That is a common area, but it can happen, actually.
Even lower down.
Lower down, actually.
Oh my gosh.
So
this is very interesting. A lot of people take this medication. See, in this part of the world, a lot of things are over the counter. But even in the West, where medications are tightly controlled, this category of medications are still over the counter. In the States, I don't know about the UK.
Yeah, I mean, UK, I think you can get ibuprofen, like smaller doses, and if it is higher dose, people can buy it from supermarkets and these kind of things. So it's not that as tightly controlled, but people are much more aware, actually, and awareness is the key. Education is the key thing, actually. So once
which
that
is kind of why we're here today, I believe. We want to educate ourselves and educate our audience. Okay, the next thing that we want to talk about with regards to medications that can be harmful to the kidney is another class of drugs that almost everybody takes, not just once in their lifetime, but several times in their lifetime, and those are antibiotics. Yeah,
again, antibiotics is, we all need antibiotics to get rid of our infection. I mean, especially if it is bacterial, fungal, or whatever it is. But certain class of antibiotics, have got an increased predisposing tendency to worsen or precipitate acute renal failure. Among that, one group of classification is called as aminoglycosides, gentamicin and those related drugs, amikacin, these kind of things, especially used for gram-negative organisms. So that, again, there is, once you are aware of it in a very good hospital setting, there are pharmacists, the doctors will be looking at their residual kidney function, and they will plan. I mean, there are algorithms and charts to find out what is an optimal dose, loading dose, and after that the subsequent doses. And sometimes preferably we monitor the drug levels itself, so that the subsequent doses can be adjusted, so that you are not poisoning someone, especially who has got compromised renal function, actually. And
well, I can still consider you a young man.
Yeah.
Myself a bit of an older man. Way back in the 70s, when I graduated from medical school, there weren't that many effective IV antibiotics for the gram-negatives. And gentamicin was the prototype back in the 70s and 80s. And it was very, very common knowledge that it was harmful to the kidneys way back then. So that was the first indication, I think. Now, as I was reading and preparing for today's program, I was kind of surprised to find some more commonly used antibiotics now, like the
cephalosporins, penicillins. They are antifungals.
Sulfur drugs also?
Sulfur drugs, virtually almost all of these drugs can cause, so ideally before prescribing, you should check actually, what someone's renal function is. Not only their creatinine value, and you can calculate GFRs or estimated renal function itself, and sometimes you have to adjust the dose actually.
Which is actually the glomerular filtration rate.
And usually it is monitored in mild, less than 50 or less than 30, or someone pretty close to dialysis or on dialysis kind of, that will be less than 15 actually. So that is where, especially in that middle range. So that is where,
And what is the normal GFR range?
Normal GFR is about 125, 90 to 125 mils actually. We don't call it anything less than 60 onwards, that is 30 to 60 is where the problem comes actually. So 60 to 90 is what minimal damage, or we would say as staging wise stage 1 kind of thing actually, whereas stage 3 is 30 to 60, that's where a good amount of general population will be sitting there actually, who have got underlying renal problems or other comorbidity, and hypertension, diabetes, these two are pretty common these days actually.
So you have to be careful about antibiotics,
especially.
Also, I was reading up that don't you have to adjust the dose also?
So there are criteria given to how much to give. Probably you may have to half the dose, or you may give only 25% or 30%, depending upon what the drug is and what your residual kidney function is actually.
So another trick with antibiotics is that as the renal function tends to diminish,
Yeah.
you must decrease the dose.
Yes, you must either reduce the
antibodies.
total dose or reduce the total frequency, or sometimes you may have to completely avoid it, actually, you know.
So that means in the elderly, for instance, even if they don't have intrinsic kidney disease, because their renal function is declining, you must definitely diminish the dose.
Anybody above 50, you need to monitor your kidney function. That is it.
I take that kind of personally.
So it's as a blanket cover, you know, because
Okay.
that helps people to
Right.
understand, you know, if my granddad or somebody is going and the doctor is prescribing, you know, has he really checked actually what is his kidney function? Then, you know, the more aware you are, I mean, the doctors also will be much more careful actually, you know, with regard to their prescriptions.
Everything starts to decline at 50, especially the renal function
Yeah.
in general. Now, we mentioned just recently the underlying common causes of renal disease being high blood pressure and diabetes. Now, also preparing for this program, I found it interesting to find out that, you know, because, you know, you and I, we talk in your office a lot about medicine and the importance, and you always remind me of the importance of monitoring your blood pressure.
Yeah.
And keeping your blood pressure down. And in the Black American population, especially in the States, the most common cause of renal failure is from hypertension.
Yeah.
Now, I found it interesting that some hypertensive medicines themselves can sometimes be not so kidney friendly.
Yeah.
And that's what I want you to talk a bit about.
Yeah, I mean, you know, because hypertension, we know that, you know, because previously people used to think, you know, if we can't find a secondary cause for high blood pressure, you know, we call it as essential hypertension or primary hypertension, you know, where there is no underlying cause. It's partly because of genetic risk factors and, you know, various other changes which happens within the body. Now we know that we need to treat it actually. If not untreated over a period of 20-25 years, it will have, you know, significant cardiovascular morbidity. And with that in view, the awareness is there outside in the public arena that, you know, people need to control their blood pressure, aiming for a target range closer to 130/80 or slightly bit more, you know, not more than that actually. And there are effective medicines as well to control it. So any blood pressure, but you should be cautious as well, you know, because if in the process of controlling the high blood pressure, if you bring it too low, that also can be detrimental to the health actually.
Yes,
and
it diminishes the blood flow.
It diminishes the blood
Cardiac
flow.
output.
Yeah. So if you're asking about any blood pressure, you know, these days what is commonly used are, you know, something called as which affects the renin-angiotensin pathway. You know, there's a class of drugs which is called as AC inhibitors and angiotensin receptor blockers, or ARB actually. You know, so they particularly affect, you know, they are significantly beneficial to the kidneys, not only apart from reducing the blood pressure, but it also has got other additional benefits in protecting and preserving the renal function and the morphology, apart from, you know, reducing the blood pressure alone itself. But again, if you combine lots of other drugs, I mean, you know, sometimes if you're taking a bit of non-steroidal or if you're taking diuretics to control your heart failure,
talk about them next.
You know, and then, you know, you just add in a little bit of AC inhibitors and you don't forget, you know, you don't monitor their kidney function, then it becomes a problem. Because otherwise, with this particular class of drugs, the mechanism of action itself, you know, everybody's GFR comes down by about 10 or 15%. That is the way it acts. So everybody's renal function may rise actually. The creatinine may rise by about 10 or 15%. That is acceptable. But the question comes in, are you doing more than that? And how can you monitor that? You need to monitor, if you start somebody on certain type of drugs, recall them back and recheck your kidney function 4, 5 or 6, you know, at least.
And the mechanism of that is because of the diminished blood flow to the
kidney?
because,
you know, AC inhibitors is usually given predominantly to reduce the proteinuria. I mean, you know, and that how it can be reduced is by, you have the afferent arterioles and the efferent arterioles going out actually of the, you know, kidney, and then the filter is sitting there. So this is what is controlled by the AC inhibitors. And when you try to reduce, AC inhibitors acts on both the section actually. So when you reduce that, actually the filter pressure load comes down, so the protein leak comes down, everything comes down. That is one action of it. But then there are other actions within the mesangium and within the cell, so that, you know, unnecessary cell proliferation doesn't happen and the kidneys, you know, don't progress into some sort of scarred stage actually. It's, you know, these things are happening
that's irreversible.
That is irreversible actually. You know, if you catch it early, you know, you can do something about it or prevent or decline the we can halt or slow that slope of decline actually. Instead of going down pretty steep,
you can level off a bit.
You can just, you know, try to bring it up actually. So
now, by ACE inhibitors, for our viewers, You mean drugs like enalapril?
Anything ending in prils,
All the prils.
and anything ending in sartans are angiotensin
Right, the sartans are the angiotensin
receptor blockers, actually. So that is one.
The sartans.
Anything. And now the irbesartan, losartan, candesartan, valsartan, all those things. Whereas the other, there is a new drug which is a renin blocker as well. That is called as aliskiren, actually. So that is being used now.
Renin blocker.
Yeah, renin blocker.
Because we're going to talk a bit about this renin-angiotensin system. That's coming up.
That apart from that, for any blood pressure, if you unnecessarily or unduly drop your blood pressure too much, it is detrimental to, because your perfusion, even the kidneys can adjust the blood.
It's a balance, isn't it?
Yeah, it's a balance, actually.
If the pressure is too high, the high blood pressure destroys the kidney.
Yeah.
The pressure is too low, the kidney doesn't get enough blood flow.
Exactly.
And the rest of the body also.
Yeah, and because of that, all these organs like brain, kidneys all have an intrinsic mechanism, what is called as autoregulation. That means beyond a wide range of blood pressure, it can control the blood flow. Whereas if you, on top of it, if you add in more drugs which will impair that, so kidneys can't cope with that, actually. So similarly, that's why if somebody is used to very high blood pressure, we don't bring it too dramatically. I mean, we gently, because their kidney is not used to, because their system is used to a very high blood pressure. And if you bring it down to what is normal, their particular organs, brain or kidneys, may not get adequate circulation, actually.
Okay.
So that is important, actually. So, and similarly for in the lower end, if you try to minimize it pretty low, and especially if they have underlying problems, or they are on other polypharmacy drugs. I mean, so you just need to be careful about monitoring the kidney function.
So this blood pressure and kidney thing is very complicated.
Oh yeah.
It's a very intricate system.
Because that's why kidneys get every minute 1,200 mils of blood, and it is sensing all the time what's happening with the body. Should I reserve more? Should I preserve more water? Should I excrete more salt? So it's a very dynamic.
Now you that third program that we talked about. That functions of the kidney. I hope we get to that, because people need to hear that. Now, you mentioned diuretics. Diuretics are known to be life-saving drugs, Lasix and the thiazides. Now, we're almost out of time, but just how can the diuretics actually harm the kidney?
Diuretics as such, it can, if it is on a chronic basis, if you use unnecessarily, again, combining many types of diuretics, diuretics with non-steroidals or diuretics with other drugs, and it can cause, it can cause volume depletion, actually. Dehydration. And, there can be electrolyte imbalance along with that, because along with you're washing away water, you're also blocking the reabsorption of sodium and potassium, and which you lose out. And people, because of low sodium, people can get problems because of, if we have low potassium, people can have, cardiac arrhythmias, or
have seizures from low sodium.
Irregularity of the heart rate, all these things. And in long term, so that is the effect of the diuretics. But sometimes diuretics also can cause this kind of inflammation within the kidney, actually.
Really?
Yeah. It's, common drugs, like sometimes the omeprazole, the PPI you mentioned to protect the, they can be,
protein pump inhibitor.
Yeah, even though it is widely used, you have to think about, if something happens. I mean, they all potentially can cause,
Speaking of medications that can cause acute dehydration of the kidney, before we run out of time, we have to mention this briefly, the X-ray dyes.
Oh, it's very, very important.
People get X-rays all the time.
Oh, very, very important. I mean, what we call as contrast nephropathy. I mean, the key thing is to, normal people who have got normal kidney function won't be at risk, actually. The risk will be less than 1%. But majority, if you have diabetes, or if you have underlying cardiac problems, or if you are taking other medicines, the risk goes up about 15-20%. The key thing is to make sure the patients are adequately hydrated before the procedure and after the procedure with normal saline. And then there are scavenging materials which we can give, which are protective, actually, which we use something called as N-acetylcysteine, actually, which you need to give about a couple of doses before and after, and that helps to protect the damage from the.
There needs to be some prophylactic measures.
Definitely, if you are at risk, you need to be, otherwise you are running in with, and there are studies to show that, if you give adequate type of prophylaxis, the incidence of contrast nephropathy comes down dramatically, actually,
And we're almost out of time, but quick question: immunosuppressant drugs.
Yeah,
You
immunosuppressant.
have some transplant patients.
Oh yeah, I mean you are one.
Yes.
Actually, I mean
Tacrolimus.
tacrolimus does not have as much renal toxicity as compared to its predecessor, something like cyclosporine.
Cyclosporine.
So people have moved away from that actually.
Thank God.
Again, and then there are other chemotherapeutic agents, which
So
we
it's
use.
ironic that this drug is saving the kidney from being destroyed by your body.
Yeah.
But the drug itself, that's why you have to measure the TAC levels.
Definitely, we need to
Yeah.
measure the tacrolimus levels. Sirolimus is another one actually,
Right.
which gives rise to renal damage. That's why in the transplant setting we always monitor, because it should be a tight balance of
Absolutely.
good and bad. Actually, you can't
Seems like
overdo.
balance seems to be the
Key
name of
thing
the
to
game.
life. Actually, that is it.
Sounds like a hadith from the Prophet, peace upon him. Thank you, Dr. Abraham.
Pleasure.
Please be back with us next week. We're going to talk about polycystic kidney disease. Dear viewers, you can contact us at Medicine Islam, P.O. Box 111, Sharjah Television, Sharjah, UAE, or by fax at 9716-5311-969, or you can contact us at our website, which is Medicine in Islam at sharjahtv.ae. And of course, we'd like to conclude our programs with a short dua, a short prayer of the Prophet Muhammad, peace be upon him, such that if any errors or mistakes have been made on this program, and most importantly, if any sins have been committed on this program, that Allah subhanahu wa ta'ala, in His infinite mercy and grace, will forgive us. Subhanallah wa bihamdihi, subhanallah wa bihamdika, wa nashhadu an la ilaha illa anta, nastaghfiruka wa natubu ilayk. Jazakumullahu khairan. May Allah reward you with the very best Islam. أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد. Welcome again, dear viewers, to Medicine in Islam, a program sponsored by Sharjah Television that features topics relevant both to the field of medicine as well as the great religion of Islam. Alhamdulillah, abdul-alim, we're continuing today to talk about kidney problems in our nephrology series. Today is part 10. In the nephrology series, our resident nephrologist is Dr. Abraham George, who is a consultant nephrologist here in Sharjah. Dr. Abraham, welcome back.
Pleasure, Dr. Bilal, as always.
Now today, as I just mentioned, we're talking about something that before we decided to do this program, I had very little knowledge of as a physician and as a patient, and that is polycystic kidney disease. I hear people talk about it. I know people that have it, but actually in preparing for this, it was quite enlightening to find out how common it actually is. So let's give us a definition first.
I mean, polycystic kidney disease, by definition, it is genetic actually in its inheritance. There can be two common things actually. One, in the adult population, what we see is something called as adult dominant polycystic kidney disease, whereas the recessive one is what we see it in the very young age group, and sometimes it is not compatible with life itself actually. So majority of the time, what we are dealing with is adult dominant polycystic kidney disease actually, and in fact, the incidence is about 1 in 500 to 1,000 live births actually, and many people don't realize that they have underlying polycystic kidney disease until quite stage, I mean in their 30s or 40s, until happen to be picked up by incidental finding or something like that actually, or a clear-cut family history is there that someone has been suffering. So because of this genetic defect actually, there is a gene product, something called as polycystin actually, that is abnormal, and that polycystin is required for the normal cell-to-cell adhesiveness actually between the tubular structure actually. So once
nephrons.
Within the nephrons, in the nephrons you have tubules. I mean nephron is, you have your filtration aspect actually, which is the glomerulus, and then you have the Bowman's capsule. Right. Then your tubules comes in actually, your your proximal descending and then ascending and loop of Henle, and so within these tubular structure, all round there is, this is all, it involves multitude of proteins.
Just kind of summarize the structure of how it happens.
Because in the tubules you have cells lining the tubular cells actually, and between that tubular structure, there are, multiple number of proteins which talk to each other actually. So polycystin is one of the important, protein, which is important for cell-to-cell interaction actually, and adhesiveness. It should be tight actually. So and it is also important for the growth cycle actually. So when you have abnormalities involving that particular protein actually, what happens is that there will be weakness inherent in that basement membrane. The cell cycle won't stop actually, it will start producing unnecessary tubular cells actually, and then everything gets misplaced.
So proliferation
is happening, and these these tubules are not really dilated, they are blocked actually, and because of there is no growth cycle arrest actually that is happening actually. So because of that, what will happen is that slowly these tubules get dilated and they start secreting as well, and as time passes by, people have lots and lots of cysts actually, and it will impair their kidney function, makes them prone for high blood pressure, and eventually majority of them end up with end-stage renal disease. I mean, in their 50s or 70s, depending upon, again, even though I mentioned
just give us an idea of how many cysts can actually exist in one kidney.
Oh, normally you shouldn't have any cyst at all. But
I mean with this disease.
As we, as time passes, as we get older, it is okay to have, what we get, simple cyst actually. But when we talk about young age group actually, less than 30 years, you're looking at 3 or 5 cysts, onwards. I mean, there are strict criteria depending upon, is it only in one kidney or both kidneys, and the age of the patient. What is the risk factor? Suppose if you are seeing somebody for the first time, without any family history, then you should be extra careful about diagnosing polycystic kidney disease, just because if you see 1 or 2.
Oh, I see. So this is where the problem comes.
Yeah. So whereas if there is a clear-cut history, my dad had, or my grandfather had, or somebody had in your family, it's easy actually. That okay, you are developing. It's likely chance if you see a couple of cysts in one kidney is enough to diagnose polycystic kidney disease in less than 30 years on kind of thing. And again, the other thing is that there are insurance implications as well. I mean, because you don't want to know about it. You see, sometimes because it affects them negatively actually, and premium goes up.
They get branded.
They get branded, right. And many things. Sometimes people can't get mortgage, loans, all kinds of things actually, which will have implications.
So what about genetic testing to prove whether or not this is a simple cyst, or whether or not it is actually PKD?
Yeah, I mean, you can do DNA analysis. First of all, it is very expensive because the PKD abnormality again is there are 2 types actually, PKD1 and PKD2 actually, depending upon what the type. But majority of them is PKD1 kind of thing.
Which
it's
is
a
dominant.
It's a big gene product actually, and you can test actually, but. Why do you want to test it actually? Because if it is, first of all, it is not freely available. We only advise testing in prenatal if somebody, a family is, have got a baby, I mean, and there is a family history, and the family is 100%, because it is not affecting the brain development or anything like that. If you're born with polycystic kidney disease, of course, you can deal with it actually, and transplantation and various other things. And there are newer therapies evolving as well actually to keep things at bay. Now, if the family is 100% willing that, I'm going to go ahead with abortion or something like that, and they want to know, then of course, there is a reason to give them, the genetic, option, analysis of the baby, or
so the genetic testing becomes more significant really with the autosomal recessive one.
Autosomal recessive, yes, definitely. I mean, autosomal recessive means both the parents are unaffected actually, but they have the
But
they're carrying the defect gene, and somehow the baby is getting affected by a 1 in 4 chance of getting that actually.
So if each of the parents is carrying the defective gene,
but they don't have problem.
1 out of 4, there's a 25% chance that the children will be born with this.
Yeah.
And that's a really serious situation.
Yeah.
Some of them even have problems in utero. I mean,
it is it's not compatible. But now with the developments in the neonatal care, I mean, sometimes they have difficult lung problems, hepatic problems, bad renal failure from beginning itself. You may have to remove the kidney to support them.
Yes.
Lungs, intubation, or long term support. All that is really bad actually.
The thing that I found interesting when I was preparing for this program, of course, amongst the African American population in the States, when we look at the genetic things, we always think about sickle cell disease. With sickle cell trait, it's not such a big deal. But when you have sickle cell disease, then that's when it becomes very serious.
Yeah.
But this is kind of like the opposite. When it's dominant, I would have logically thought that the dominant type of PKD would be the more serious one.
No,
but actually, it's not.
No. You can. It is compatible with life. I mean, obviously, you have
you can deal with it.
You can deal with it,
Yeah.
and people need reassurance and importance about lifestyle management. You shouldn't be smoking and controlling their blood pressure. Regular monitoring, and there are medicines as well. Actually, these days, tried in clinical phase 3 trials. That's going on actually.
Let's talk about the symptoms, because you said the dominant type usually doesn't manifest itself until the adulthood, in the 30s or 40s. What would be some of the first symptoms?
People just manifest maybe headache. Development of high blood pressure is not everybody with polycystic will develop high blood. Maybe 50% of them will develop, and of that probably 50% will develop end-stage renal failure. But what is more important is to get a history actually. If your family history is very important. If it is available. Is anybody in your family have got this, or have they been on dialysis? It means it's good. It's a good reflection of what is likely to happen to you as well actually. Okay. Or similarly, we ask a family history for brain hemorrhage or headaches, these kind, because sometimes some of them have got abnormalities involving the blood vessels, involving what we call as aneurysms or weakness within the blood vessels, which can rupture. And if that is the case, family history very good. Is there any family history of strokes or sudden deaths or something like that?
Yes.
Means we can screen them and give them prophylactic. If the aneurysm is big, they can be clipped or whatever it is actually. So high blood pressure is one thing, and its manifestations is the other. People can sometimes present with, because of the cyst actually.
The size of the cyst.
Loin pains. Loin pains can happen.
Where do they get the pain?
In the flanks actually.
In the flanks?
It's in the flanks,
okay,
where the kidneys are. And it can be so big, and it can bleed. The cyst can bleed by itself actually.
Now how big can they actually get?
Oh, they can be really big, to the extent that, sometimes when we go for, the best treatment is transplantation. Once you reach that, end stage.
It's nothing to do with take it out.
You may have to take it out actually. If it is so big, I have seen, patients where the full abdomen is full of, 2 kidneys.
They can get up to be like 20, 30 pounds? Is that?
No, yeah. Pretty,
unbelievable. And normally the kidney is about the size of a fist, so to speak.
Yeah.
And what's the normal weight of a normal kidney?
It's about grams. Exactly.
Grams.
Yeah. We'll be talking about kilograms.
We're not even talking about a half kg here.
Yeah.
Maybe a half kg.
Yeah.
But not a kg.
No, not at all.
Definitely not.
No, the polycystic can be very big.
No, but normal kidney size or weight?
15 grams, something like that. 15, 25 grams, that's it.
And you compare that to
No, we are talking, pounds or kilograms. It's big because your abdomen is full of, the cyst actually, space actually.
And you mentioned the abdomen. Now, it's not just the kidney that gets the cyst. Now, in autosomal dominant, also you see it in the liver, right?
Yeah, liver also can be involved. Pancreas can be involved. Sometimes, the ovaries can be involved. The fallopian tubes can be involved. They can be, they'll be prone for
fallopian tubes.
Yeah, because they'll be prone for ectopic pregnancies and these kind of things, weakness within. I mentioned,
it's the same pathology.
The same pathology because it is important in the ciliary function as well. The polycystin 1, which is the common one actually. The polycystin 2, and always there is an interaction between these two, protein products actually. So once your cell growth as well as the cell-to-cell interaction is impaired, all these things happen actually.
Well, when you mentioned one key word that just stuck in my mind, that's prostaglandins. So I guess now, when there's a problem with prostaglandins, you're going to see a problem with the female organs, because prostaglandins also have a bit of a connection sometimes. I didn't know that this also could occur in the fallopian tubes.
Yeah, it is predominantly because of the ciliary action and
Ciliary action.
Yeah, because all the tubular structures have got cilia, and it is it acts as a conduit to transport something.
They brushing everything out.
Yeah,
just like in the lungs.
Yeah.
Yes. Yeah, the cilia. It's supposed to brush everything out. But does this action usually in one direction? Or is it sometimes
no, both actually. It just
so
tries
the lungs is
to
only in one direction.
Yeah,
it's
just
moves. Bringing everything out.
Oh, I'm not an expert on ciliary action.
Interesting. Ciliary action. I haven't heard that word in a long time.
Because it's
now, what other organs can be involved? You mentioned the liver. You mentioned the pancreas.
Yeah, I mean, liver is important. I mean, because sometimes it can give rise to what liver fibrosis can happen, and because of that, they get something called as secondary portal hypertension. Actually, so basically the liver, gets both the systemic as well as the venous, blood flow. And once the liver becomes tight, actually you can't flow, and there will be back pressure, and that results in spleen getting enlarged, or varices, or big dilated things, esophageal varices, or around the perianal region, hemorrhoids. So and they can bleed.
Now, the person with esophageal varices will actually die from acute hemorrhage.
Yeah.
And if it breaks loose and start hemorrhaging, you can bleed to death.
Yeah, I mean, polycystic usually don't. I mean, the death in polycystic kidney disease is predominantly because of cardiovascular risk factors. So that is why tightly controlling your blood pressure is important, actually. And and the associated
blood pressure is one of the most common.
That is what gets you actually. So you try to get that tightly under control, and then there are other things as well. If your renal function is worsening, there are many things which needs to be looked at.
Now, I was reading also that you can actually have abnormalities in the valves of the heart.
Oh yeah, you can get actually, you can get something called as floppy valve,
floppy valve.
What we call as mitral valve, because it shouldn't close. It is a bit loose. Yeah, a little bit of regurgitation, and again there are gradings actually. So. What is the correct name? It's slipping my mind.
That's okay. I got the point.
It's the
now, and the same similar pathology with the aneurysms.
Aneurysms is predominantly, aneurysm is just weakness actually. Basically, your whatever your structure is not pretty tight actually. So you have weakness within the brain vessels actually. Berry aneurysms, that is what we call. If somebody gives a history, somebody with polycystic kidney disease, if they say that they have a family history of stroke or sudden deaths or headaches, you just need to look for. And family history is pretty important.
Those things can be fixed if you know.
Yeah, I mean, if you pick it up, because a stroke, and bleed, the consequences is pretty bad.
Absolutely.
Absolutely.
Absolutely. Subhanallah. Now, with regards to, let's talk more a little bit about the recessive one, because I found it to be, so much more traumatic on the small babies. And then there's one that's called infantile PKD, which is, of course, even in the womb, or just at the time of birth. Some babies, they live just a few hours.
I mean, because of the recessive nature, and because the majority of them, they'll be surprising. I mean, maybe you're talking about mortality rate of 50 to 75%. So they don't survive that perinatal period actually. And
so for that group of
it's a totally different.
The genetic testing is an absolute must.
Genetic testing, I mean, if something has happened actually in the first pregnancy, and then you are getting pregnant, but yes, in that kind of for the second pregnancy, but the first time you will be able to identify these things prenatally itself actually. With these days there are pretty good prenatal screening, but it's an awful thing, and it is pretty bad. I mean, it affects the child or the baby in a big way actually.
Absolutely. Now, we're just about out of time. There's two things we want to touch on. First of all, diagnosis, which is probably pretty similar for both types. How do you diagnose?
I mean, the key thing is to just do an ultrasound scan, and that is the way to pick it up. And plus, look for other family history or other associated features, whether they have hepatic involvement or ovarian involvement and these kind of things, So that way, you get a diagnosis.
So is ultrasound sufficient most of the time?
Yeah, most of the time it is enough actually. I mean, or sometimes, if you are in doubtful, you can do it serially getting a family history. I mean, if you can get a family tree, and easily and
That's
get
very
that,
important.
that is very, very important.
The history is very important.
So
now, is there any situations or circumstances where you have to do an MRI, you have to do the more advanced
definitely,
testing?
I mean, because there are, we don't routinely do it, but if there is a risk, actually, I mean, if the cyst can be pretty complex, actually, sometimes, there can be a malignant transformation. If that is the case, you may need to delineate it very well. You may need to do CT scans or MRI, or if you are going to do serial follow-ups, actually, or if you are on treatment, ultrasound may not be a very good idea
to baseline.
Yeah, because it is, based on whoever does the ultrasound. There can be a variation between whoever operator variation, what we call that. Whereas with the CT and MRI, it is it's everybody. You see it, I see it. Everybody, it's the same thing actually, and it helps.
That's what they call it, imaging.
Imaging,
because you can imagine it very easily. You can see it very easily. So sometimes you do need to.
Oh yeah. I mean, to find out if it is complex things.
Now,
we are
of course,
dealing.
now, lastly, you've touched on it briefly, but just for our viewers, treatment.
Treatment, as I mentioned, I mean, because the cardiovascular risk factor, I mean, the key thing is to tightly control their blood pressure, preferably use ACE inhibitor or angiotensin receptor blockers, or these days, we have renin blockers, statin, healthy lifestyle, statins to control their cholesterol. Nowadays, there are, vasopressin receptor blocker, antagonists, which is called as tolvastatin, actually, which we use to, prevent the regression or to prevent this growth of the cyst, actually.
Okay.
And so that, and even sirolimus is being tried actually to prevent, to reduce the cyst size, especially
slow it down.
Slow it down, actually.
You.
So all these things need to be, it's in early phases. It'll come mainstay maybe in few years' time.
Then
actually,
antibiotics for the UTIs.
Antibiotics and for treatment of infection, and then sometimes they may need blood transfusion if it is really bad, or otherwise all the treatment what we use for chronic renal failure, and that matters actually as their renal function decline, and then ultimate and the definitive treatment is transplantation, actually.
Transplantation is the ultimate
once they reach to that stage, but we can do a lot more to prevent that decline and
slow it down as well.
Stabilize, actually.
Absolutely.
The prognosis has tremendously improved now.
Thank you so much, Dr.
Pleasure.
Ibrahim. Unfortunately, we're out of time, viewers. You can write us at Medicine in Islam, P.O. Box 111, Sharjah TV, Sharjah, UAE. Or you send me a fax at 9716-5311969. Or you can contact us at our website, which is Medicine in Islam at sharjatv.ae. And as our custom on Medicine in Islam, we'd like to conclude all our programs with a short dua, a short prayer of the Prophet Muhammad, sallallahu alaihi wasallam, peace be upon him, such that if any errors or mistakes have been made on this program, and most importantly, if any sins have been committed on this program, that Allah subhanahu wa ta'ala in His infinite mercy and grace will forgive us. Subhanallah wa bihamdihi, subhanakallah wa bihamdika, wa nashhadu an la ilaha illa anta, nastaghfiruka wa natubu ilayk, nastaghfiruka wa natubu ilayk, nastaghfiruka wa natubu ilayk. Jazakumullahu khairan. May Allah reward you with the very best Islam.